the COVID-19 burden in the U.S. with Dr. Monica Swahn, Distinguished University Professor in the School of Public Health at Georgia State University, my alma mater. The moderator is our good friend, Ramesh Subramaniam, who's a member of the Members Forum Steering Committee and who organized today's program. Ramesh is a partner in a company called Consequent, and Monica will tell you what that means in Swedish. Today's program is brought to you with the support of the UPS Foundation and you, the members of the World Affairs Council. I'd like to give a special welcome to Eric Joyner, member of our board of directors, to Peter Zimmerle, the Consul General of Switzerland, and Kwan Suk Lee, the Deputy Consul General of the Republic of Korea. We're going to try something new today. A number of people had commented that they wanted more interaction. And since we purposely kept today's audience smaller, so you have to be a member of the World Affairs Council, Members Forum, I want to ask you to keep your microphones muted, but your camera on if you want. At 12:20 or so, Ramesh will move to questions from the audience. And you're going to need to unmute your microphone then, and we're going to let people ask questions live on through the Zoom platform, and we'll see how this works. And so with that, Ramesh, I'm going to turn this over to you. It's your program.
Thank you so much, Charles. Good afternoon to everybody. I'm so glad that you all have this chance to have this conversation. I'm super delighted to introduce Dr. Monica Swahn. Actually, it's been something I've been wanting to do for a while, for what, maybe quite a few months ago, when I first read Dr. Swahn's personal story in the Georgia State University magazine. And it was actually a very, very interesting story. And I thought to myself, well, that's be an interesting person to talk to about COVID-19. And so I'm really glad this has all come together. You know, Monica brings a very interesting perspective. First, you know, she's an epidemiologist and with 10 years at CDC and knows that organization very well and what all it could have done, what it has done, what it's capable of doing, etc. So she's got that background. She's a professor at Georgia State University again for more than 10 years and teaches a global health class to graduate students. And so she has this sort of context of understanding that from that perspective. And last but not least, she also has a very personal connection. I mean, originally from Sweden and has a personal sort of background connection to COVID. So I think with all that perspective, I couldn't think of anybody better to have this conversation with. So Monica, thank you for taking this opportunity to sort of have this conversation with us, and welcome.
Thank you, Ramesh, and thank you, Ambassador Shapiro. It's really exciting to be part of this member forum. Really enjoyed the programming that you've had and very excited to be a member of the organization. So thank you, Ramesh, for that introduction. And maybe with that, maybe I should actually start talking about why I wrote that blog. I had written a personal blog on my GSU blog site, my first and only actually. And the GSU alum magazine put it up and shared it more broadly with an audience. Of course, they asked first. And the reason why I wrote the blog was that I felt, and I wrote it in April, and it was because my dad passed away from COVID in Sweden. But the context of this was that as a global health professor at Georgia State, teaching our master's students about all things global health, when we started the semester in January, and we of course started seeing the numbers about what were later be labeled COVID, we made a point of talking every week about what it looked like, how it was spreading, what the risk was of it coming to the US. I, at the time, was much more focused on Africa. As a global health professor, I do a lot of work in East Africa, and I was very concerned about the, inadequate healthcare and, lack of potential capacity. Most of our work in Uganda, they have a lot of experience with Ebola, but some of the other neighboring countries aren't as well equipped. So the students and I talked about this every week as we were talking about all the other global health topics for the class. But as I was coming back from a trip to Ireland in early March and the numbers were starting to surge, we really saw, of course, what was going to be a changing landscape forever, and we're still in it. But the odd thing here is that I had shared with my friends and family that you know, COVID, sure, it is going to be a big, I mean, most likely will become a pandemic. You know, we see how fast it's spreading. The world is global. People are traveling, all of that. But I really didn't think it was going to manifest in the US the way it has. People ask me, is it, you know, what are we going to do? And I said, well, we have this under control. I worked at CDC for some 10 years. I've trained the disease detectives. Contact tracing and testing, I mean, the things that we do for other infectious diseases, we have the infrastructure to do that. I'm sure we'll figure it out. And then everything just changed. And every morning, you know, and all these platforms are starting keeping track of all these cases. I just watched with horror and fascination in terms of how the numbers were creeping up and faster. And those of us who are math oriented and know about log curves, I mean, we see, you know, how fast these rates were just multiplying. And then, of course, you know, the rest is history.
Monica,
in terms
before you go down the log curve and stuff like that, which we probably all, you know, we all have studied it. Now you're going to remind us how much we didn't pay attention then. Before, maybe just going to level set a little bit. Maybe could you even sort of provide some context to the situation that is present in the U.S. that perhaps led to that, you know, the specific COVID-19 burden in the U.S., if you could.
Yeah, no, and I think that because it was spreading so fast, right, we were really wondering, what are the drivers of this? Why is it spreading so fast? So as I mentioned, I mean, we were expecting contact tracing and testing, but in the absence of that, I've asked myself for the last couple months, why has the vulnerability in the U.S. been so high? Given our healthcare system, given that we are a relatively educated society, given all the infrastructure we have in place. So I spent more and more time thinking about our non-communicable diseases, our chronic diseases, if you will, heart disease, cancers, we can even put mental health in that bucket. So a lot of underlying health concerns. So someone like myself who's been focused more on social issues, psychiatry, and chronic diseases in my public health career, have been stunned in terms of how many reports have written about the health disadvantage in the US. There was a really critical report almost 10 years ago that outlined that the US, compared to its peer nations, are worse off in so many health metrics, whether, again, we're talking about HIV/AIDS, whether we're talking about cancer and heart disease, and a whole host of health concerns. And so I'm just like stepping back and looking at the 30,000 foot level. I'm thinking as a country, our health, we were worse off as a starting point. So we were not sort of physically, from a health perspective, ready for a pandemic. And I'm not sure any country really is ready like that. But if we think about how much money we spend on healthcare and our healthcare expenditure per capita, we usually rank way over any other country. So it's not necessarily that we spend more in terms of healthcare, but what do we get out of it on the other end? Our health profile, whether we measure infant mortality or we measure life expectancy, does not show that we're healthier than other nations. And I think that health disadvantage really exacerbated the pandemic coming to the US. And in terms of course, how we responded is another issue in and of itself. But had we been healthier as a nation, I think the numbers would have also looked very different.
Got it.
Does that help? Is that kind of what
that really helps? I think when I talked with you first, I mean, I hear about the other dimensions related to, how we didn't do things right or what we did, and et cetera, et cetera. But this notion that underlying that we already had a health crisis or a health challenge even prior to COVID-19, that was a very interesting perspective that you brought. I think that was very helpful. So, now that you talk a little bit about, now you can get back to the log curves and the specific things and so on that you were sort of going down there. Talk to us a little bit about what we did here in the United States and how does that sort of contrast a little bit with in the situation in other countries.
So I think that's a really important question. And of course, the scenario in the US has changed over the last couple of months and has changed in other countries as well. So the US, I think, because we didn't see a national response, that we saw so much of it varied by state, it's very difficult to talk about the US response overall. I mean, this morning when I went and I looked at what the numbers were across states, I mean, we see much more of the surge now in the Midwest. In many rural areas that we didn't think we were going to see these level of outbreaks. And also in Europe, many countries that have done really well over the summer and early fall are now seeing outbreaks on a whole new level. You mentioned I'm from Sweden, of course, so I follow Sweden more closely, and I've been hoping to go back there to take care of my dad's stuff. But they are actually talking in Stockholm, which is the capital, about potentially implementing some restrictions in Stockholm as a way to deal with the new increase in cases. And the Swedish model, I think, has been criticized quite a bit because they were going with this kind of herd immunity. And if you're not familiar with it, it just means that about 60 to 70% of the population will get the disease and therefore become immune. But that's a very high number. And as we've seen, the death toll is very high. Most countries opted to not go that route. But Sweden, of course, did not have the health disadvantage I just talked about for the US. I mean, Swedes tend to be healthier and live longer lives and have, less kind of health burden than we do here. And they also live very differently. The many Swedes live by themselves and not have the bigger families that we do here. So there are a lot of reasons why the Swedish system and the country and the population is totally different than we are here. So they have been criticized in Sweden for having a fairly high mortality rate for COVID, at least compared to the Scandinavian countries, the other Scandinavian countries that went for a much stricter type of approach. So we'll see. I mean, it is not over yet. As many of the people who do the modeling for COVID are really thinking that there's going to be a surge this fall, and we might already see the beginning of that a little earlier than anticipated.
Got it. So when you talk about and I know when we talk about successes, and a lot of times people refer to countries like Taiwan and Singapore, and countries like that. One of the things that I've heard is that also that has helped them a little bit is this being prepared for SARS and other diseases in the past. And so could you talk to a little bit about that in terms of how that plays a role in being prepared as a nation?
Oh, absolutely. I think many of the countries, in particular in Southeast Asia, like you mentioned, Taiwan, Singapore, etc., have a total different view and in total different kind of, I don't know what word to use here, but people really listen to the governments and maybe mandated to listen and follow instructions. In the US and in Europe, we have much more of an independence, right, in terms of guidelines and what we can be told what to do. So I think the experience with previous infectious outbreaks, even though they may not have been as significant as this one, really some level of preparedness that we didn't see here in the US and even in many of the European countries. So their response was swifter. I think they understood the numbers much faster. They really mobilized, again, more quickly than I think other countries. And because of that, they really handled things very, very differently and had a much better response.
Yeah, the other thing that was interesting, I know, is, I think there's also the dimension of cultural, because I hear a lot about, the mask wearing is probably one of the best. And recently, even, Dr. Redfield came out and said, if one thing you do well, you can wear the mask and so on. And I know culturally that, even a 2-year-old kid in Japan, I lived in Japan for many years, a 2-year-old kid in Japan is used to wearing a mask. And so it's just normal for them. But that's not always the case in other countries, places like New Zealand and Australia and so on. So the wearing mask is probably more common in Asia and less common in Europe. So how did that help, in other places where they didn't have that culture already?
Well, I think that is right on. I mean, wearing mask is the best strategy that we have. And I really appreciate Dr. Fauci and Dr. Redfield highlighting that. It is a little puzzling to me why it has been so challenging for us to accept that. But again, having not really had to wear masks, I have not had that familiarity. I think we felt that it was something other countries do, and why should we do it here? So that resistance, and of course it was politicized in a way that I don't think any of us could have predicted. But we're back to the basics, because it's going to be a long time until that, vaccine is ready. Best case scenario is going to be mid-time next year, probably. So the mask is the prevention tool that we have. And it's cheap, it's easy to do. It's just a matter of using it. But of course, we see all over the country, people are choosing not to because they feel like it's infringing on their personal freedom.
Yeah.
So we have that huge challenge. And unfortunately, we don't have time. And we've already seen the surge because you know, when we do health promotion campaigns, it takes time to change people's behavior, especially for people to do something they don't want to do. I mean, we've had analogies with people wearing seatbelts and all those kind of things, but with that, we had more time. We had more time to kind of work with it. I mean, here we have an infectious agent that is working in real time, and people are spreading it whether they know it or not. I mean, we have to assume it is everywhere.
Great. No, that is interesting. And you're right. I mean, some of that stuff, you know, you hear about success of seatbelts, and I know, I mean, I came to this country in '85, and, you know, it's amazing how in the matter of years, you know, cigarettes and how that sort of thing changed. There's a tipping point there, and, you know, so on. So, you know, that behavioral change is probably, you know, is going to take a little longer. On this front. But coming back to the question we talked a little bit about, so can you talk a little bit more about Sweden and the other Scandinavian countries? The reason I want to talk about that is in some parts, you know, that is a microcosm of what's happening in the US. There are parts of the US that are behaving like Sweden, that says, no, we're just going to not, you know, restrict it, and let's do a more laissez-faire approach to it. And then there are parts of the US that are more like the other Scandinavian countries that says, no, let's put some more restrictions. So in some sense, you know, different parts of India, different parts of the US are sort of behaving like different parts of Scandinavia in some sense.
Well, and I think, you know, I think you're exactly right. I mean, so we have huge variability across the states, and we have huge variability within states, right? So this becomes very challenging. But I think, as I was mentioning earlier, we are now seeing a surge of COVID transmission in the Midwest. Yeah. And I think many of those states didn't really see the need of having more restrictions in place. Many of them are very rural. They had very low number of cases. There was really no evidence of high levels of community transmission, which we're always concerned about. So they didn't see the need for it. And I think, so even though many of them didn't want to wear masks and didn't want to make any restrictions, they were perhaps not prepared for the surge that they're seeing now. So the surge we're seeing, you know, post Labor Day, post people going back to, kids going back to school, universities going back to school, people coming back from vacations perhaps. So interacting in very different ways. So, and like I said earlier, because we didn't have a national kind of a federal strategy across the states, states had to make their own decisions, and challenging ones at that, given the variability and heterogeneity within states. So, but of course, as we know, I mean, people going on vacation, I mean, we saw people traveling to Florida when there was a surge of cases there and taking it back to wherever they came from. Same idea with some of the sports game and some of the other, what we call the super spreader events, that people come from many different areas and then they go back to where they came from and they take the virus with them, whether they have symptoms or not. And that is really key, that people are still spreading it when they're asymptomatic.
Got it. Now, as you're talking about differences in state and so on, can you talk a little bit more about Georgia specifically, sort of bring it down home? We talked about it globally. We talked about Europe and Asia, and now let's sort of bring it home. What are your sort of observation thoughts about what have we done in Georgia correctly? What can we do going forward?
I mean, so the good news today is that the numbers are looking a little better than they were just about a week or so ago, but we're still not out of the clear. You know, we're still, I think the positivity rate is still way over 5%, and 5% is that marker that the WHO says.
What does positivity rate mean?
Sorry, positivity rate meaning, so out of 100 tests given, how many of them are positive for COVID? So a 5% positivity rate, meaning that 5% are 5 out of 100 test positive. And so WHO set this marker of 5%, that if you're under 5%, you're good, you know, you should maintain 5 or less, you know, and then things, that means that the community spread is relatively low. Now, of course, the tricky thing here in Georgia, and I think it's eased up a little bit, but people are still complaining that it's been hard to find a test or find a place to get tested. And they've also had to wait a long time to get their test results. So because of that, we had many challenges in managing the community spread, meaning that people didn't know they had it, or people had it but weren't sure if they had it. Right. People took a test and still waiting for the results, but then they assumed they didn't have it. So many of those kind of layers to it. So, you know, I think that we still have to be very vigilant in Georgia. You know, it's toward the end of September. Many of the schools are back, but I think many of our schools, including our universities, have adapted really well and really tried to mitigate the risk by, doing the distance learning and really focusing on the social distancing and really make sure that campuses are as safe as they can be. And so we'll see. I mean, we'll hope that we'll stay on track. We've, of course, heard many horror stories from universities all over the country where there have been substantial outbreaks and where universities weren't quite ready for those outbreaks and how to handle it. I mean, having people living in the dorms all of a sudden have to pack up and go home again, or, not sure what to do if they're going to close down the universities in a hurry. And the same thing goes for the education at the lower levels as well. So very, very tricky situation. But the good thing is that it looks promising for now. Unfortunately, the flu season is about to hit. We're encouraging everybody to get flu shots. And of course, there's great concerns in terms of in the healthcare system, how to differentiate people who have what we call regular flu versus COVID, and what this is going to look like in the next month or two. So we really have to be vigilant and really encourage people to wear their mask and social distance and stay home as much as they can. That's really the best way to get through the next couple months.
Yeah. On that one thing, you talked about tests. A question to follow up, maybe it's more a personal question, but just I think it would be helpful to everybody. I mean, there are, tests that sometimes take a week or so for the results to come back. And what I've been reading is that's really not very helpful because, if somebody is tested and is tested positive, it's that period of about 3 days, that they are the most, the viral load is the highest and they're infecting others the most. And so, from your perspective, what tests are good? Because there are some that are rapid tests, and I read about them that says, oh, that's not very effective, and false positive and false negatives with those. So what is your sense of what is, if one of us has to do it, which test would you sort of point us towards as the most useful one?
Well, I mean, at this point, I mean, it is really challenging still to make broad recommendations like that. I think people should get tested if they think that they've been exposed, if they think that they're sick, or they've had any other reason for why they have been exposed. And while the test is pending, or the test result is pending, obviously take precautions, right? Because again, I think there are a lot of spread that happening in that window, just like you outlined. People take the test and they're like, oh, well, I'm still waiting for the results. I can go about my business the way I was. And no, I mean, that I think is our weakest link in the transmission, from the transmission point of view. And I've heard both good and bad. I mean, obviously the fast tests are exactly that, they're fast, and fast tests tend to be less reliable than others. But I think these still obviously serve a very important need here. In terms of communicating with people. I know for people who want to travel abroad, they really need to have the PCR test, the one where you have to wait longer to get on a plane and travel to most other countries. And so that is still challenging for people to get it in a reasonable timeline.
Okay. Great. So just one more last question, then I'm going to everybody get ready for being open for questions, because as you know, the members forum, the most fun part about it is the questions from the members and so on. And so I guess my last question would be is, as you think about universities in the US and you're back to school, Monica, do you feel like, are there some differences to highlight between what, I know we're not doing consistently across all universities, just as we're not doing it the same across all country on a broader sense. But any observations about universities in the US versus universities in other international countries?
So, I mean, I've been surprised by how many different strategies and different models our U.S. institutions have come up with, and I certainly understand the challenges. These are not easy decisions to make, no matter what plan you come up with, balancing, teaching and safety and, just the financial aspects of it, I'm sure has been a huge component. So in the US, I think because we're such a large country and we have so many institutions of higher education, we've seen many different models. In Europe, I've seen it vary quite a bit. I'm not sure I should speak too much on this, but I think France and some of the universities in Paris that recently had outbreaks, they had in-person classes in crowded classrooms where the students seemed to say that they couldn't really socially distance. I think Germany and some other countries have been much more focused on the distance learning and online, like many of our universities here. In Scandinavian countries, I couldn't really see what they've been up to. I assume that they've been in person, but it's something I would have to check on. So okay. I think it's kind of very similar to how the country as a whole operated during the pandemic and what restrictions they put in place. So it is interesting to watch and of course very potentially sad. but also because universities most of them are just getting back into business right now, and it's very hard then to tell which model worked. I mean, this is a conversation to have in a couple months, and of course then it's too late for others to adapt. I mean, that's just the way it is.
Yeah, no, that's great. No, thank you. Thank you for all those sort of opening sort of thoughts and comments that sort of sets the stage for this discussion. So I would like to now sort of open the floor, so to speak, to everybody for any questions. And as you can see, you know, Monica's got a great background in lots of different areas. And so you can, you know, pose the question either from a global perspective or from an epidemiology perspective, or, you know, whichever perspective you'd like to take it. And please, yeah, I mean, before, since is there a way for me to know, Charles, about who wants to try to figure out?
Yeah, the screen will light up when they start talking. And so,
okay.
you have to turn off your microphone if you want to ask a question.
Please, whoever, just do that. And if 5 of you talk at the same time, then I will have to moderate, but I'm sure we'll all do perfectly fine. So whoever wants to go first, please go ahead.
Go ahead.
This is Jorge Fernandez, and Monica, thank you for your discussion. Could you talk a little bit about vaccine? It seems like every day we picked up a paper or hear the news. It seems to be a race from different corporations all over the world, actually, in terms of a vaccine. But what I get as a consumer, what I get is there's a rush from the commercialization of it. But what's the process? How do I trust from the health perspective that we're getting what we should, rather than Johnson & Johnson today announcing that they're going to do 60,000 tests, and Moderna and so forth and so on. Could you talk a little bit about that process and how do you gain trust on it?
Sure, I can. Vaccine is not something that I usually deal with, but I think just giving sort of the higher level picture here, I'm concerned, like everybody else is, given how it's been portrayed in the media. I think we have about 4 of them in the final kind of testing phase at this point, which is great, because we know that there are always things coming up at the end as things are being tested, and we see how people react to it. But you're exactly right. I mean, what company wouldn't want to have the successful vaccine that is going to go out to these large number of people, maybe for multiple years? And there's also been some preliminary research indicating that we might actually need multiple shots, because again, it might not be that the shot is going to give us the immunity that we really need. So there are a lot of questions up in the air. And unfortunately, because so much of the COVID piece has been politicized, I think we are talking about these vaccines in a very different way we would have, as we've done with other diseases or other vaccines. So I'm also concerned in terms of what the public, how we are transmitting this information to the public, what the perceptions are of vaccines. I mean, as you know, in the US in particular, we have a good portion of the population who are anti-vaccines, period. And so how do we deal with that to make sure that the people understand and really believe that the vaccines are safe and efficacious and ready for distribution to this larger population group? And I think that's why we're seeing the FDA, I think it was in the news this morning or last night, talking about really having that scientific scrutiny and making sure that the public believe in the science and believe that the vaccines are ready when they are. But most of us do not believe that there will be a vaccine on this side of the year. I mean, even Dr. Fauci and Dr. Redfield talk about it probably mid next year or toward end of next year to be ready for larger public consumption by the US or distribution to the larger public. So I hope that between now and then, we can be reassured that whatever is working and however it's going to be distributed, that it's safe, and they can show us the data on that, and that communication strategies around this has really improved. Because right now I feel that most, I mean, again, the communication around all these issues with COVID, whether it's testing and other issues, have been really confusing with changes, whether, you know, who's going to get tested, when are you going to get the results, and what are the risks. And, you know, it was even the conversation about the transmission with the air droplets and things like that. So we have to streamline the communication. People are confused and they're exhausted, I think, with all the different information. And with vaccines, we cannot mess that up. That has to be for real.
No, great. Anybody else? Question?
This is Jessie
Amanda?
Legros. I have a
Oh,
question.
sorry, Jessie. Go ahead, Jessie. Amanda, sorry.
So now that the winter months are almost upon us and we'll be spending more time inside, what are some suggestions to decrease the possibility of acquiring COVID-19 through indoor transmission?
Yeah, no, so thank you. I think it's a great question. Oops. Sorry, my stand fell off. I've been trying to hold it with my hand. No, it's a really great question. And it's not just the indoor transmission, it's also how it's going to be interact with the flu season, right? Flu and cold season that is coming up for most of us in the fall and the winter months. So for indoor transmission, I mean, people can wear masks indoors, and in some cases that has really been encouraged. Even in families that are multi-generational or families where you know, some people may not be able to protect themselves, they still have to go to work and so forth, and commingling. Dr. Fauci and others have even suggested that wearing a mask in the house is really might be the prudent thing to do, even though it might seem odd. Social distancing and hand washing, exactly what we're doing in the outdoor environment, but things will be much more challenging indoors in different work environments, school settings, universities, and all those when we have people in closer proximity. So social distancing is really going to be key. Really important question. Thank you.
Great. Amanda, you.
Hi, thank you so much, Monica. We really appreciate this discussion. My question is, I wanted to get back to the issue of how politicized lockdowns, masks, social distancing, all of the various guidelines, how politicized it's become here. And I was wondering your view on how much that has contributed to our rising death toll. And then also, I wonder where else have you seen this sort of virus politics play out in the world, like on a similar scale, or I just wonder your view on that.
Yeah, no, thank you. Maybe that is one of the hardest questions of all to answer. I don't think any of us could have predicted that it would have become this politicized. And I cannot say that I've seen it in really any other country quite like that. And of course, there might be situations and contexts that I don't know about, so reservations for that. But in some African countries, I know that they were overcounting and then undercounting. I mean, there's been all kinds of mix in terms of reporting, but nothing compares to what I think that we have experienced here in the US. And as an epidemiologist who's all about the science and using the science, in a way to protect the public and prevent disease spread, it's been really shocking and surprising to see that it's been politicized. You know, we mentioned mask wearing earlier. Like, who would have thought? I mean, nobody loves to put on a mask. I mean, that is not the point. But again, in the absence of other strategies, it's low cost, it's easy to do. It's not 100%, nothing is 100%, but it is very close. So the fact that we've had to deal with these challenges, I think, has really exacerbated the spread. And back to what I was mentioning too in the Midwest, because now in the end of September, we know about the spread, we are measuring it much better, we are at least scaling up testing capabilities and so forth. So the fact that we're seeing these surges in the Midwest now, it's almost hard to explain given that we know and we have so much more information. So I think it is very, very unfortunate, and it's hard to predict. Implemented a lot of these measures, you know, hand hygiene, masks, social distancing earlier. But the point is, we can still, if we were to implement it fully right now, we would avert many more deaths, because again, here we are, 200,000 deaths. It's such a grim figure. It really didn't need to be this bad. And here we are, we're still counting, and we're not even close to done. So I really hope that somebody could figure out how to untwist all this and give us kind of a new fresh start, if you will, in terms of moving forward, because it is just sad to watch.
Yeah, on that front, Monica, one of the things, observation is that, you know, you said, yeah, some other countries are more fortunate that they have a structure that sort of allows for a single national policy on this. And in our case, because we make those decisions at the state level, at the county level, and so on, so it's distributed. But even then, if it's distributed, having a common directive or a direction or an advice or the State Department does it all the time. When you go, people, individual citizens go everywhere, they provide advisory, they provide a recommendation, and more people than not follow the recommendation. And so if there was at least a recommendation that was consistent, even though everybody makes their own decision, there might be a better chance of that recommendation being followed, correct?
Mm-hmm. Absolutely.
Okay. Anybody else for a question?
I've got a question.
Sorry, Eric, I'm going to Keith first, and I'm going to you next, if you don't mind. Go ahead, Keith. Keith, we can't hear you.
Right there. Can you hear me now?
Yes, we can.
Okay. I'm sorry I came a little bit late. I had a company meeting beforehand. Testing seems to be, how about this? Where in Georgia, let's bring it home, where in Georgia can one get a simple, time-effective testing? I mean, you know, you'd think this would be a logical primary step, but I hear, you know, tales, you see it. My wife's been tested hours in a car or standing in line. How do we, or is there a testing on the horizon that's a little more efficient?
That's a great question. I think the poor infrastructure in terms of testing, in particular in a state like ours, was really detrimental to the community spread. I mean, it's really unreasonable to ask people who are that sick and feeling so ill to sit in a car for so many hours just to get tested, right? I mean, they are really, really sick. So I think I've heard improvements. I have not gotten tested myself. I've been fortunate not to have been exposed, I guess. So I mean, I feel like I hear some positive news here and there, but overall, I really can't speak to that, how long people are waiting. I mean, I had a neighbor who had to get tested because he had to fly somewhere, and he had to go to 3 places to find it, somebody would give him a test results in time for his flight, and 2 of them still didn't come in on time. So it's really, I think, challenging still. At the university, I've been impressed, Georgia State where I work, that we have a web page with a lot of resources. And of course, we have some in-house capacity for our students, staff, and faculty. And I'm very pleased about that. But of course, all work situations are different, and many people don't have access to that. So it's something that I think we really need to, it's not too late. We can still improve it, right? We need to improve it.
So if you're at GSU, you have adequate testing.
I mean, I've not gone there myself, but I looked at the numbers on the website and their resources. And so I think that it's been we've had very few numbers of COVID cases on campus. So it looks very promising.
But it's available to you.
Mm-hmm.
Or Charles, it's available to Charles. He disappeared.
Yeah.
That's the main thing. Is it available? Mm-hmm. Is it efficient?
Yeah, so, no, those are key questions.
Are you saying it's random?
I'm sorry, what?
Yeah, are you saying it's random?
Keith, so I think the sense is, that is an area that is definitely an opportunity. But I know for universities seem to be doing a better job because they're able to, it's a more tighter, set of, the universe is smaller. They're able to
sure.
Mm-hmm.
But the universities are doing a better job in the broader community.
If I had to put in a plug for Georgia State too, I mean, obviously our university president is a public health expert, so that might have also helped. I mean, we have leadership that have been really, strong public health leaders, and that might have changed things too.
And I think, Monica, you and I talked about earlier, the other reason Georgia State has the numbers are much lower is because there are not as many people all staying in one dorm together. So because it's a more a city, an urban campus where people, a lot of them are sort of coming in, commuting into classes and so on, even before. So I think that has helped a little bit at Georgia State too. But Eric, you had a question. I'm sorry.
Thank you.
Monica, how does this all play out? I don't have an understand what the end game is. If we keep doing like we're doing, and it's 6 or 8 months or a year before the vaccine is effective, and the vaccine's only effective for 50%, how does this play out? How do you see this ending? Will the virus eventually go away, or we eventually have a herd mentality, or how does it play out?
That is more than $1 million question, isn't it? No, I mean, and what can we say about that? We have all kinds of predictive modeling, and I didn't even say that we have a fantastic colleague at Georgia State who does predictive modeling, and the challenges that goes into assessing, different policies, whether it's at the state level or local level, and how people behave. Are they putting on masks? Are they socially distancing? You might have seen all that work with the cell phones, keeping track of how people were moving across the country during our lockdown. So I don't know. I don't know how to answer that question. I think it is a fantastic question, but you're right. Even with the best of vaccines right now, we are not sure how effective they will be. And I think that is why, we have the coronavirus task force really emphasizing mask and social distancing are the tools that we have. It might be that the vaccines are going to be better than we think. We don't know. And so what does this all mean for us going forward? It is kind of a grim scenario. I mean, at some point, maybe we'll hit herd immunity, but I would imagine that would take years. Best case scenario, because if we move it faster, we obviously have an even higher death toll, and that's not something that we want to see either. And again, I want to make sure, there's a point that we didn't cover here that I really wanted to make sure too. We have had a horrific death toll in the United States, no doubt. I mean, 200,000 people is still counting. But the morbidity, I mean, we have almost 7 million cases in the US, many of which have recovered fully and successfully, but many of them which have not. We call them long haulers, the people that have symptoms, for weeks, months, and maybe forever. We don't know because it's not been around for long. So the fact that we talk about prevention and protecting people is that we don't know in which bucket any of us will be in, whether we're going to be hit hard by this or we're going to be asymptomatic, of course, unless we have some other, what we call them pre-existing conditions or comorbid health concerns. So those are still going to be here going into the future. So I don't really know what to answer to your 30,000 foot level question. And given that we've not really put all the things in place by now, meaning September, it really means that we have to be better in communicating with the public in terms of how to protect ourselves, how to protect each other, and how to get our work done with these kind of caveats.
But it certainly looks like any business that's depending on density, like stadiums or concerts or anything like that, or restaurants, going to have a hard time for a foreseeable future.
I think so. I did a media interview for an outlet in Iowa. There was a huge stadium that was going to do a football game, and some 70,000 people. And of course, that was before they hit their big surge of cases, and they canceled those plans. But I have a hard time imagining that we can have those numbers of people come together. Even if you do a small percentage of that, it is very risky when we have this level of community spread. If we ever got to the point where we got under that 5% positivity rate and we knew that spread wasn't high in the community, and we could really follow people who had been sick, follow them, meaning that we could do the contact tracing and isolate them and so forth, like they've done in many other countries, it'd be a whole different story. But we've never gotten ahead of the curve. And I guess that's what I'm trying to say. We've just never been able to implement that fully in a way that we have with other infectious diseases in the past, and been very successful with that in the past. Okay. So it's not too late. Obviously, we have time to prepare. I mean, we don't have a great starting point now, given where things are, but we can certainly turn things around. Public has to be willing, and everybody has to come together to join us on this effort. Because as soon as some people don't, then we're back to where we were.
Got it.
Thank you.
We have time for one last question. Anybody has?
Yes, I have a question.
Yes.
Thank you for joining us. And would you explain the difference for us between trying to create a vaccine for a DNA virus versus an RNA virus, which, if I understand correctly, the common cold is an RNA virus as well as COVID?
Yeah, that's a great question. I'm not really the best person to answer that question. I'm sorry for that, in terms of what the implications are and the spread going forward. I've not read up on that, and so I'd be on shaky ice, or thin ice, as we say in Sweden, in terms of answering that. So I really can't.
Anybody else? Quick question.
Yeah, if you don't mind, I have another question, if we have time. Maybe Monica, this is on your field. You mentioned about the positivity rate being around 5%, which is good. I believe Georgia is around that number, correct?
Today it's a 7.4%. So we're just hovering a little bit above that. Yeah.
Above that. However, the hospitalization rate in Georgia is one of the highest. What if the cases are sort of controlling? We are 7% on the positivity. Why is the hospitalization rate that high compared to other states?
Yes, I mean, it is so many questions, right? And we have all these different metrics in terms of measuring the spread and morbidity and mortality and all of that. And sometimes we need to look at them all in concert to understand what the picture is, what the environment is like. So I think in Georgia right now, hospitalizations have been falling, which is great. But again, they started out much higher. So why is that? I think in Georgia, we are a state where we have huge disparities in terms of chronic diseases and all kinds of health conditions, and also a lot of inequality in terms of resources and socioeconomic status. And I think because of that, many people have gotten COVID, have needed medical care and hospitalization. So it's back to the point I was talking about earlier in the terms of the US not being physically or physically prepared, if you will, for a pandemic like this, because so many of us have been in poorer health. And so in states where I think we've seen more of these disparities or large populations in poorer health, COVID has required much more in terms of medical care, hospitalization and treatment and ventilators and all those aids to help people get through the disease. And that's not really going to change here in Georgia because we can't change those health conditions that fast. And so I think that COVID is going to stay with us for that reason and transmit in people being more receptive and getting sicker as a result of it.
Got it.
Makes sense. Thanks.
Thank you so much. Thank you. I know we're at the time here and we could probably continue on for a while, but thank you so much, Monica, for your time and your insights and a very, very interesting perspective that you brought to it. So thank you so much for for making this possible. For those of you that are interested in this topic, there are a couple of other upcoming programs that you may want to consider. So there is a COVID-19 What We Know So Far program that's coming up on the 29th of September. And then there is another members forum next month on COVID-19 and housing by Jonathan Reckford, the CEO of Habitat for Humanity. So there are two related topics, one in September 29th by the SVP at the Center for Strategic and International Studies on COVID-19. And then on October 1st, the CEO of Carter Center, Paige Alexander, is talking about the success of the Carter Center. So these are some upcoming programs. Look forward to seeing you all on those programs too. And thank you all for joining for this members forum today.
Thank you, Ramesh.
Thank you, Ramesh. Thank you for the invite and thank you for the great questions.